before, so they know exactly what to expect. So what we'll do is we'll just run through each of these 4 cases, and I'm going to invite you guys to describe some of the radiographic changes that you can see in each of the cases, and then to provide some conclusions, and the conclusions should contain a ordered list of differential diagnosis, and you should be able to justify the order of differentials that you've given for each case. When you receive the cases, and I try to get them out at least 1 week in advance, I wouldn't spend more than about 15 minutes on each case. One of the things that I used to do when I was attending film reading evenings at Cambridge is just to split up my report into 3 sections: findings, conclusions, and recommendations. For the recommendations, I try and stick to imaging recommendations. So if you think that the patient might benefit from an abdominal ultrasound, for example, or a thoracic CT, then I would include that in the report. So without further ado, let's get on to case 1, which was a 5-year-old crossbreed dog that presented regurgitating and pyrexic. And I think Giorgio had expressed an interest in presenting this case. So over to you, mate.
Thanks, Ian. We've got right and left laterals and a DV of the thorax. I felt as though the esophagus was slightly distended, but not enough to call it Megaesophagus or anything like that. So I was kind of looking up other things that kind of affect the esophagus, like redundant or kind of hiatal disease. And I thought perhaps, whilst I was trying to look for these things, I didn't spot it initially. I thought perhaps the most likely thing was sliding esophagus. So I was trying to convince myself that there was kind of that soft tissue opacity between the aorta and vena cava. So I'm not sure if it's right or not, but I thought I can kind of see that just between them.
So you're looking at this area here.
Kind of there, just slightly left of where your red marker is. Yeah, right, there. Okay. So I don't know if this is completely wrong or not, but looking out of the diseases that affect the esophagus in the book, I thought that is probably the most likely one. Okay. Looking back at the case now, that wouldn't explain why it was pyrexic, so I think I'm probably wrong. But that was what I thought for this one.
Okay. So let's just go way back to the start, and you've given me some possible differentials there, and your top differential was a sliding hiatal hernia. Before we get to differentials, just describe some of the radiographic changes that you feel are present in this radiograph before we start talking about what the most likely differentials are.
Okay. So I thought there was kind of mild esophageal distension. Okay. I think there was maybe a subtly increased soft tissue opacity diffusely, but I'm not sure.
Okay.
Or perhaps a little bit called a dorsally, if it's not to do with esophageal disease. Perhaps slightly underexposed on all 3.
All right.
I can't see any abnormalities other than that.
Okay. No, that's fine. All right, let's open it up to the floor. Does anybody else have anything they would like to add to Giorgio's radiographic description?
I do. So in this one, in the left lateral, I will say that there is megaesophagus, because you can clearly see both radio opaque lines delimiting the esophagus, which is not normal. Yeah. And then if we go to the right lateral,
good.
There we are.
Okay.
I would say there is a bronchial pattern.
Okay.
Because you can see kind of like the donuts. Which will be probably a little bit of aspiration pneumonia, maybe.
Okay. So, I mean, a bronchial pattern is not what you'd expect to see in a patient with aspiration pneumonia. So before I let you have that as a diagnosis, you're going to have to just expand on your description. Convince me that you know what to look for in a patient that has aspiration pneumonia, and describe it based on what you can see.
I guess you will see changes on the caudal lung lobe.
Yeah. Well, so
Caudal medial more than the cranial ones.
yeah. So I mean, when we've talked about trying to decide the origin of parenchymal changes, we've said that if we see an increase in opacity and it has a dorsal distribution, then it's more likely to be edema. Heart failure in dogs, characteristically, it'll be hilar or in the dorsocaudal lung lobes, whereas pneumonia tends to have a ventral distribution. The distribution of change for pneumonia, and that would include aspiration pneumonia, is ventral, and typically it tends to be the right middle lung lobe.
Okay, so I'm wrong in that. Then my other question is in the cranial lung lobe. So there's like kind of like a structure there.
This thing.
Yeah, what's that?
Yeah. So what that is the right cranial lung lobe overlapping the left cranial lung lobe. So what I can do is I can show you on a CT scan how the right cranial lung lobe expands and almost traverses the midline and goes from the right to the left side. And in a radiograph, you get this sort of appearance. So you get sort of a crescent-shaped soft tissue opacity. It's much easier to see on a CT. But this structure here, that's just normal anatomy. Okay. And what I can do next time is I'll load up a CT scan and I can show you the reason for that. So the right cranial lung lobe just expanding and moving from the right to the left and overlapping the left cranial lung. Just normal anatomy. Okay. So I absolutely agree with your description of the dilated esophagus. So you're right. We've got a linear soft tissue opacity in the dorsocaudal thorax, and we've got a similar linear opacity just dorsal to the caudal vena cava, and they represent the dorsal and the ventral walls of the esophagus. So the other little buzzwords that we can use here are a tracheal stripe sign. So not so much in the right lateral, but in the left lateral. If we look just dorsal to the trachea, just cranial to the hilus, we can see that there's this kind of thick, well, relatively thick, soft tissue opaque structure, and that's the dorsal tracheal stripe sign that it tends to be used when people describe big dilated esophagus, and that's probably appropriate to use here. So there's a dorsal tracheal stripe sign. The other thing that you can sometimes see is the musculature ventral to the cranial thoracic spine. I think it's called the longus capitis muscle, just outlined. So you can see a very clear straight margin there. You don't normally see that, and that's because of all the gas in the esophagus. So big, diffusely dilated esophagus. So this isn't a focal dilatation that you might see with, say, a vascular ring anomaly. This isn't a redundant esophagus. So a redundant esophagus is something that you sometimes see in brachycephalic dogs like bulldogs, and what that looks like is sort of a curved gas opacity, just ventral to the trachea. So I can maybe look for an example of redundant esophagus. But this isn't a redundant esophagus. This is a megaesophagus. It's big. It's diffusely dilated with gas. So this is definitely a megaesophagus. So you also mentioned the sort of problems that you might see in a dog with megaesophagus. So associated with it, and aspiration pneumonia being one of them. And you're absolutely right. But we haven't really got to the point where we've described the changes here that allow us to make the diagnosis of aspiration pneumonia. So is there anything else in either the right lateral radiograph or in this DV radiograph that might make us think that this dog has aspiration pneumonia?
So is it on the DV kind of just to the right of the heart, that increased opacity? Is that describing the right middle lobe?
So this is the right side here.
Oh, sorry. I guess left middle then.
So here.
Yeah, is that?
Yeah, absolutely. So here there is a very poorly marginated focal increase in opacity, and if we had to try and nail it to a lung lobe, it's probably the left cranial lung lobe. Now that isn't typical for aspiration pneumonia, but in this DV view, if you look at the opacity of the lung here, it's certainly increased relative to the rest of the lung. So compare the opacity here to the opacity here, the opacity here, and right the way up the right side. So there's definitely something going on here. Now, because this is the left cranial lung lobe that we're concerned about, it's going to be the right lateral view that is most likely to reveal what's going on there. So in the right lateral view, it'll be easier for us to see the left lung because it's the non-dependent lung, so it's not going to be collapsed. So is there anything in this radiograph, and it is reasonably subtle, but is there anything you guys can see here that might nail it on as aspiration pneumonia? So you're about 80% of the way there because you've picked up this focal increase in opacity. That's not normal. This dog has a megaesophagus. So now we're concerned that there might be an aspiration pneumonia. Can we nail it on and see some other lesions in this right lateral view that make us very suspicious that this dog has aspiration pneumonia? And again, this is to the floor now. So if this is our cardiac silhouette here, and if you guys look very closely, do you think these structures are here? Yeah, so I don't know if you guys could hear that, but Luke has just suggested those are ear bronchograms, and he's absolutely right. So these tree-like gas opaque structures are ear bronchograms, and if you can see ear bronchograms, then that means there's consolidation of the lung, and you can describe that as an alveolar pattern. So we've got consolidation here because we can see ear bronchograms. It's in the ventral part of the thorax. If we look at the DV view, it's most likely to be the left cranial lung lobe. So with the megaesophagus and the ear bronchograms in the ventral part of the left cranial lung lobe, we can say that we're very highly suspicious that this dog has aspiration pneumonia secondary to its megaesophagus. In fact, it certainly does have aspiration pneumonia. So yeah, that's the answer. This dog has a megaesophagus and aspiration pneumonia. So good job. Just for fun, possible differentials for a dog with megaesophagus. So what can cause megaesophagus?
Is myasthenia gravis one of them?
Yeah, myasthenia gravis is one, yeah. Anything else?
You can have a congenital or an idiopathic cause of it.
Yeah, absolutely. So congenital, familial.
Hypothyroidism.
Yep, absolutely. Anything else?
I've got lead toxicity spring to my mind. I'm not sure
that's right. You're absolutely right. So like heavy metal toxicities, so lead, zinc, cadmium, other toxicities, infectious things like botulism can do it. It's been described in dogs with tetanus as well. Anything else? So we mentioned hypothyroidism. I think some other endocrinopathies can do it as well. I think potentially dogs with Cushing's and Addison's can have megaesophagus, and sometimes dogs with diabetes as well. I think it's sometimes associated with thymoma, weird neuropathies can do it. So like polyradiculoneuritis, like lupus, that kind of stuff. So there's a whole bunch of differentials. The first thing to check really is you can sometimes see megaesophagus in dogs that are anesthetized or sedated. So you can have a look at the trachea and see if there's an ET tube in. I don't think there is one in this dog. So it probably isn't secondary to anesthesia because it doesn't look like this dog was anesthetized when these radiographs were taken. But there's a whole bunch of potential differentials to consider in a dog that has a megaesophagus like this. But the most important thing here is that it's got a megaesophagus. It's probably regurgitated and aspirated. And the reason why it's pyrexic is because it's got an aspiration pneumonia. All right, cool. Good job. So case number 2 is a 2-year-old male Cocker Spaniel that presents to you as vomiting. So I've given you 3 radiographs. You've got a right lateral, you've got the BV, and then you've got a left lateral. So who fancies this abdominal series? Don't all volunteer at once. So, Maita, because Giorgio did the other one, I'm going to ask you to do this one, I think.
Okay, that's fine. So we have here a right lateral radiograph of an abdomen of dog, in which we can see two populations of intestines.
Yep.
So I would say you can clearly see how some of the intestines are really small and air-filled, because
Yep.
they are radiolucent, and then there are some that they are quite dilated.
Okay.
Especially in the cranial part of the abdomen, you can see a loop quite dilated, and you can see kind of like the crossover. And there is also a radio opaque structure in the middle of the abdomen, which I don't know what it is.
So yeah, this thing.
Yeah.
Okay.
I don't know if it's causing the problem or not.
Okay. Let's see.
And yeah, and that one I would think is causing the problem, because it's kind of like in the middle, and if you follow it, kind of like from there you can have both of the patterns of the intestines. You can see on one side, you can see that it's dilated, and on the other side is less.
Okay.
So my differential will be a foreign body.
Okay, yeah.
But then in this one, with a second, what is that structure cranial? It's like looks like an interception, but I don't think you can diagnose that in radiographs. So if you point
yeah, I mean, it's tricky. They're much easier to diagnose with ultrasound. On radiographs, they tend to just look like a soft tissue mass, essentially.
Okay.
So which bit are you looking at here?
A little bit dorsally, dorsal. That?
This?
No, there. There you are. So you can see that where you are is like dilated, and then if you move slightly to the left, there is a tiny bit coming in, but I think it's my imagination.
Oh, this thing here?
Yeah.
Okay, yeah. I mean, so I agree that this is certainly a dilated loop of bowel.
Yeah.
The question is this large bowel or small bowel? Now, we can follow the colon cranially, and then we kind of lose it. And then there's this sort of strange looking loop of bowel here, which looks like it could be filled with feces. The opacity of the material that is within the intestinal lumen here is very heterogeneous. It's very stippled in its opacity. It almost looks like it's got gas stippling, which is kind of weird. It could be feces, but if this is the colon, then it's in a pretty unusual place. It would be very ventral. So it remains to be seen what this structure is. Is it small bowel? Is it large bowel? But it certainly looks unusual. I absolutely agree with your description of there being two populations of small bowel here. So whenever you see two populations of small bowel, that's always a concern for obstruction. One empty population of bowel, and then one population of bowel that is more dilated, so either filled with gas or fluid. So we've got a loop of small bowel here that has a little bit of gas in it, but looks relatively normal. And then we've got these other loops of bowel here and here that are a little bit larger. The distribution of the bowel here is also a little bit abnormal. So we've got two loops of bowel here that are sort of stacked on top of one another. Whenever you see stacking of bowel, that's again something to be a little bit concerned about. So that's not a normal distribution of bowel. And for me, the opacity of the abdomen here is a little bit fuzzy. So I think there's maybe potentially some loss of serosal detail there as well. In the DV view, what we're really trying to do here is decide whether this structure here is large bowel or small bowel. And so we need to try and look for the colon. So the colon's usually on the left side. So the colon's just here. And we can see a bunch of fecal material in the colon. And as we follow it cranially, and we can see this big loop of bowel here, we're thinking, well, I suppose that could be colon, I suppose. I mean, and if it is colon, then that's probably nothing that we need to worry about, because I mean the colon can be full of gas, and we don't need to worry too much about that. There's a whole bunch of gas in the stomach here as well, which always makes me a little bit concerned. So, I mean, the features from these two radiographs that just make me a little bit twitchy are, as you say, we've got two different populations of small bowel. We have some loops of bowel that look quite dilated, and we're quite suspicious that that might be small bowel. We've got some loss of abdominal serosal detail. We've also got a loop of bowel, which, if it's small bowel, really is quite dilated, and if it's large bowel, then it really is quite displaced ventrally. So those are all things that make me think that there's something going on in this abdomen that we need to be concerned about. And the last view, so the left lateral, I mean, we're taking a left lateral to have a look at the pylorus and also the duodenum. So in the left lateral, the gas is going to go to the non-dependent part of the abdomen. So it's going to go to the right side. So it's going to highlight the pyloric antrum, the pylorus, and the duodenum. So this is gas that's sort of moving towards the pylorus. It's difficult to really be confident about what the duodenum is here. But again, we've got like a big loop here, and we can't really connect that to the large bowel. We've got a big loop here, and again, it's difficult to really be convinced that that's large bowel. Then a bunch of smaller loops that are all sort of squished up in the middle, and then this big loop of bowel here that maybe that is colon, but I don't know. It certainly could be small bowel. So, what would be a recommendation here?
I will probably stick the ultrasound probe just to see if I can see anything more.
Yeah, no, I think that's fair. So let's say the ultrasound is broken.
Okay.
So you don't have ultrasound, but that's a reasonable suggestion. So I mean, if we were at Hampstead looking at these radiographs, then yeah, popping an ultrasound probe on would definitely help. But you don't have that option in this case.
Then I will cut it.
You're gonna cut it? Yeah.
Yeah.
Okay. All right. So let's have a vote. Who thinks we should cut this dog? So Luke thinks we should cut it.
No, I don't think we should.
You don't think we should cut it? Okay.
Don't lie, Luke. We know you want to cut.
So we've got the surgeon saying that she wants to cut it, which is not a huge surprise. So who else thinks we should cut this dog?
I would have said yes, but I don't know. Your question's making me doubt myself.
So anybody else voting for cut?
I would probably go in the middle and re-X-ray it in 4 hours or something if the dog was stable.
Yeah.
Just because I can't see a radiopacity that makes me certain of a foreign body. There is that material, but I think that's probably a red herring in the colon, and I'm not sure whether that's fecal material or something like a linear foreign body. It doesn't have the balls in that area that we're discussing, like fecal balls. But if the dog is stable, I'd probably
the dog's stable.
read it. Yeah. I'd probably, but I'm more of a medic than a surgeon.
Yeah.
So.
Yeah. Okay, cool. So we've got sort of two. You said Luke said hold, but don't cut.
No, I would blow some air up the dog's bum.
Oh, okay, yeah. So that's reasonable. So Luke has suggested doing something called a pneumocolonogram, which would be helpful here.
Would that help you then if that loop bowel is long or small?
Yeah, absolutely. So Luke's saying that in this DV view, we're really struggling to try to decide whether this here is small bowel or large bowel. Now, if this is small bowel, then it's huge. And I mean, that really makes the decision for us, and we really need to go in if this is small bowel. So this would be a reasonable candidate for a pneumocolonogram, which is really easy, so that the dogs do need to be quite heavily sedated or anesthetized, and you just blow air up their bum, essentially. So about 8 mils per kilo, and you just squirt it up their bum very slowly, and obviously if you come across any pressure, then you stop. And then once you've done that, then you retake the radiograph, and then the colon is full of gas, and you can be very confident about which loops are colon and which loops are not colon. So a pneumocolonogram would be a reasonable and potentially very useful thing to do in this dog. All right, so we don't have any additional images of a pneumocolonogram for this patient, but what I'm going to do is I'm just going to point out something for you guys to have a little think about. So what do you make of this thing here? And this thing here? And this thing here? Is that something we should worry about?
That looks abnormal, I think. No?
Yeah, I agree. I mean, this thing, whatever it is, it has a very oval shape, and it has a very consistent shape. So, I mean, it's the same shape and size in every single view. So it's very clearly marginated. It's ovoid, and it predominantly has kind of a gas lucency. So what is that? I mean, if that was just fecal material, then, you know, as you're moving the dog over, as the intestines are moving around, then, you know, the kind of fecal balls and the stuff that's in the bowel, it kind of tends to change shape. Nothing normal and anatomic that's kind of within the GI tract, it kind of is that consistent and has such a beautifully oval shape with such clear margins. So what is that is the question. And having pointed this structure out to you guys, are more of you inclined to cut this dog now, or are we all still going to sort of sit on the fence a bit?
I guess would that be more likely to be the foreign body, because things cranial to that would be distended then? And
yeah, so, I mean, this if this is a foreign body, and it certainly could be, then I mean, it looks like it's within the lumen of the bowel that's contiguous with this loop. And this is really dilated, this loop of bowel here. And if this is a foreign body that's in the small bowel, then this dog definitely needs to be cut. So the fact that we've picked this up means that we should be erring more towards cutting this dog than not cutting it. And again, you can see it here, and then there's this big loop of bowel here that's got this very speckly stuff within its lumen. Okay, so this dog does have a foreign body, and it did need to be cut. So the next question is, what is it?
What the hell is that?
What is that? And what is that?
That's what I was thinking. Like, it's kind of like airfield.
Yeah. What is that? And then, so this is foreign material, and all this is foreign material. And I know that because this dog was cut, and they pulled a bunch of this stuff out of it. My question to you is, what the hell is it? And in fairness, I didn't know what the hell it was when I was looking at these radiographs, but it is kind of funny. And once I tell you what it is, you'll instantly recognize it. So this dog quite liked attacking teddy bears, and this dog had a little teddy bear with a squeaker in it, and this dog attacked the little teddy bear with a squeaker in it and ripped it to pieces, literally ripped the guts out of this teddy bear, including the little plastic squeaker and a bunch of fluff, and then promptly ate it all. So this thing here is the plastic squeaker from inside the teddy bear, and it's plastic and it's full of gas because it's a plastic squeaker, and that's what they look like, and that's exactly how I'd expect it to look on the radiograph. So it's got this more opaque periphery, and then it's got gas lucency in the center, and all this stuff is all the fluff from the middle of the teddy bear, and that's what it is. So it's a squeaker and a whole bunch of fluff from the middle of this dog's teddy bear.
What about the radiolucent stuff?
This radiopaque stuff here.
Yeah.
I think that's just kind of mineralized stuff in the bowel. This was
incidental.
Yeah, absolutely. So it's this thing that we need to worry about, and it's here, and it's here, and then it's this big loop of bowel, and knowing whether or not that's small bowel or large bowel. That's. And there's a whole bunch of other things that we've discussed as well that mean that we should be a little bit concerned about what's going on in this abdomen. But those are the key features here. There's certainly some changes here that are compatible with a mechanical obstruction. So the two populations, the dilation, the stacking, the slight loss of abdominal scrotal detail, and then this ovoid, clean marginated radiolucent structure, and this large loop of bowel with this heterogeneous stippled material in the center of it, which turned out to be a squeaker with a bunch of fluff. So this dog had surgery and did fine, had an enterotomy, pulled all that stuff out of it, and made a full recovery. So that's what a squeaker looks like, essentially.
And they never squeak on abdominal palpation. It's a shame, right? Might be easier.
I don't think this one squeaked when his abdomen was palpated. That's a nice case. I mean, and these the dogs definitely do eat. I mean, I wouldn't really describe it as a fabric foreign body, and it doesn't. The pattern of the bowel here, it's not really sort of plicated enough for me to say that this looks like a linear foreign body. It's the squeaker and then all this fluff that gives it away. But these are nice radiographs because they have a bunch of radiographic features that are compatible with a mechanical obstruction. And you know what? If you hadn't seen this and maybe you'd taken some radiographs in 6 hours and you saw this again and you'd gone in and you pull this out, that would have been fine. The important thing is to recognize that this is not a normal abdomen. This is not a dog that you just send home. There's lots of stuff going on here that mean we should be a little bit concerned. All right. So number 3 is the orthopedic case. So number 3 is a young female greyhound that has a shifting forelimb like this. I know that Maita just did the last one, but you kind of wanted this one. So you can do this one, Maita, or you can pass it to the floor. Up to you.
I'm happy if someone else wants to do it. Okay. I don't mind.
All right, it's entirely up to you. Shall we open up to the floor first and see if there are any other takers?
Yeah, cool.
Is anyone feeling happy to just describe these orthopedic radiographs? So we've got carpi, we've got left and right, 2 views, mediolateral and dorsopalmar.
Yeah, I had a go at this one.
Right.
If you're happy for me to do it again.
Yeah.
Sorry, let me just open it up on my computer. On the first X-ray, I think we have the dorsopalmar view of the manus, and then the lateral view. So I thought kind of on both the right and left thoracic limbs, you can see kind of irregular kind of transverse radiolucencies just affecting the distal metaphyses of both the radius and ulna.
Okay.
I couldn't find anything else, and I wasn't really sure what kind of conditions caused that. But I think what fit best was hypertrophic osteodystrophy, and it kind of fit with the age as well. So I thought that was the top differential.
Okay. No, I absolutely agree. Does anybody else have anything to add to this case?
I thought it was a panosteitis.
Panosteitis. Okay. So explain to me your reasoning for a panosteitis.
Shifting lameness. I mean, this the signalment of the animal, young animal with quick growing with shifting lameness. Yep. They usually affect long bones. I don't know. It kind of looks like fingerprint.
I wouldn't disagree. The distribution here doesn't really fit with a panosteitis. So as Giorgio said, it's the metaphyses that are predominantly affected here. So in both the right and the left, we can see we've got this really heterogeneous radiopacity of the metaphysis of that distal ulna, and it's also affecting the radius as well. It almost looks a little bit moth-eaten. There's not a huge amount of periosteal reaction, and the physis still looks normal. We've not really got any thinning of that physis or any sclerosis associated with that physis, but it's the metaphysis here. It's the metaphysis in this distal left radius, and the changes are bilateral. So we've got similar changes affecting the right limb and the left limb. But it's the distribution that panosteitis is maybe slightly less likely than something like a metaphyseal osteopathy or a hypertrophic osteodystrophy. So those things are the same. I think in America they tend to call it hypertrophic osteodystrophy, and in the UK and Europe we tend to call it metaphyseal osteopathy. Is much more likely. That's what it is. So any of you guys ever seen one of these on clinics?
No, never.
Yeah, so they're definitely out there.
It's a good pickup, Giorgio.
Yeah, absolutely.
Can I just ask a question just while we're on it?
Yeah.
I'd never even heard of it before, but the book said it's kind of self-limiting.
Yeah.
It's a self-limiting thing, but it was saying that you can't differentiate it between like a hematogenious osteomyelitis.
Yeah, absolutely. Yeah.
Is that true? Okay.
Yeah, that's absolutely true. So, I mean, the other big differential here would be an osteomyelitis. So, you know, the changes here are, for want of a better word, aggressive. So, you know, we've got this moth-eaten opacity, so there is evidence of lysis. So we wouldn't be able to say, we can't say this is definitely not a hematogenous osteomyelitis. Now, I mean, the dog would need to be pretty unlucky to have both the distal, radial, and ulnar physes of both its forelimbs affected in an identical way, but that can absolutely happen. So a hematogenous osteomyelitis is definitely on the list of differentials here, and we can't say for certain that it's not that just looking at these radiographs. It's just the signalment kind of fits. It's a very young dog. It's a big dog, so it's kind of a greyhound. It does have the shifting forelimb lameness. And the changes here and the distribution, so it's the metaphysis that's affected. The epiphysis looks normal. As far as we can tell, the diaphyses of these long bones look normal, and that's really where we'd expect to see the changes if it was a panosteitis. It's just the metaphyses. So it fits beautifully with metaphyseal osteopathy or hypertrophic osteodystrophy. There's this other thing called pulmonary hypertrophic osteopathy, which is not quite the same. That's where you have a lung tumor and then you get palisading periosteal reaction forming along the diaphyses of the metacarpals or metatarsals. So there's three things there. It's very easy to get those three mixed up. So HOD, so hypertrophic osteodystrophy, and metaphyseal osteopathy are the same thing. That's what this is. And then this pulmonary hypertrophic osteodystrophy, that's where you have changes affecting the distal limbs, so palisading periosteal reactions secondary to lung tumors. But yeah, this is metaphyseal osteopathy. So yeah, nice job. Any other questions about this case? Everybody happy?
Yeah.
Yep.
Cool.
Yeah, happy.
So number 4, which is the last one, is a 2-year-old male neutered pug presenting with acute onset dyspnea. All right. So is there anybody other than Giorgio and Maita that wants to take this one on, because they've been doing all the work so far this evening? I've given you 2 radiographs. You've got a right lateral and you've got a DV radiograph of this young puglet.
Yeah, I don't mind having a go. I've had a quick look earlier,
go for it.
if that's right. So,
Yeah.
Obviously with the signalment, there's lots of causes for concern for the dyspnea. On the lateral view that we can see here, the first thing, I guess, is that the lung fields are very reduced in size. They're radiolucent, but they're very small and displaced dorsally. There's no clear cardiac silhouette that I can see, and within the thorax, there's sort of effacement of that clarity that we would normally expect, and I can't clearly see a delineation for the diaphragm at this time. I can't see any particular pattern within the lung fields that I can see, but they are very reduced in size, so it's a bit difficult to assess. That would be my main sort of findings on the lateral.
Yep. All right, let's have a quick look at the DV.
Yeah, so I guess that supports the same kind of thing. Still got very small lung fields present, but it's not clear that you can see a cardiac silhouette particularly.
Yep.
See some gas in the stomach, and to my mind, there maybe looks like more contents in the thorax that shouldn't be there than I would normally expect. Again, I really can't assess the lungs very well. It looks a little bit like on the right side. There's some radiolucency there that might just be the lung fields being displaced that way, but I can't clearly assess a cardiac silhouette or the rest of the chest.
Yep. All right. So what do you reckon? It's a nice radiograph description. So what could this be?
Has it got some sort of herniation of abdominal contents that's then in the chest and effacing the silhouette and pushing those lung fields dorsally?
Okay, yeah. And that's a possibility. Anything else?
You could have an effusion in the pleural space that's
absolutely
displacing those lung fields.
Yep.
And that could be a number of things.
Yep.
Or you could, I suppose, have, I don't really think this is right, but cardiac disease that's causing the cardiac silhouette to look incredibly enlarged and some other fluid around the heart. But I think in this breed, in that presentation, that's less likely.
Yep. Okay. Great. So we've got a couple of differentials. So the effusion, I absolutely agree with. So you use the term effacement of the cardiac silhouette, which is beautiful. So you're absolutely right. It's really tricky to see the cardiac silhouette either in this lateral view or in the DV view. And we've got quite a uniform increase in opacity, particularly of the ventral thorax in this lateral view, and more cranially in this DV view. Okay, so any advances on Fran's description and differentials from the rest of the floor? Anybody else willing to make some suggestions as to what might be going on with this little puglet?
I don't know if that can be, but could be a lung torsion.
Okay, so what makes you say that?
The pleural effusion.
Yeah, so I mean, you definitely do get an effusion with the lung lobe torsion. However, there's a bunch of other stuff that causes pleural effusion. So I mean, pleural effusion is definitely not pathognomic for a torsion. So it's definitely on the differential list. Yeah, good suggestion.
I guess that consolidation on the cranial part.
Yep.
Could fit as well, no?
Yeah, absolutely. So, I mean, the fact that we have got a uniform increase in soft tissue opacity in the cranial thorax would suggest that there's a degree of consolidation affecting the left cranial and potentially even the right cranial lung lobes. And we've got this sort of uniform increase in soft tissue opacity in the cranioventral thorax as well. Not really seeing any bronchograms, but there's definitely a suggestion that there could be some consolidation of the cranial lung lobes. So if we're talking about lung lobe torsion, we need to think about which lobes are usually affected and which breeds are usually affected. So who would like to volunteer to suggest what breeds and which lobes are usually affected by lung lobe torsion? Is a pug a breed that tends to get torsed lung lobes?
Is there right?
Larger breeds.
Ooh. There were two voices speaking in unison.
Yeah, Georgia, you can go first.
Sorry, no, I was just saying I thought it was generally larger breeds, kind of like giant breeds again, torsion, but I'm not sure.
Yeah. So I think we might have touched on torsions in one of these sessions before. So you're absolutely right. So they're big, deep-chested dogs, like Afghans. They get lung lobe torsion, and it tends to be the right middle. But this isn't a big, deep-chested dog. This is a pug. So do pugs get lung lobe torsion?
I think they do, no?
Yeah, they do. Pugs absolutely get lung lobe torsion.
Is the right medial the one that they have usually affected?
So it's right medial in big, deep-chested dogs. In pugs, it tends to be
cranial.
So I think that the left cranial is the most common, but it could be either the left or the right cranial. So lung lobe torsion is definitely on the differential list here. So as well as the consolidation that we've already mentioned and the effusion, those are both things that you'd expect to see with a lung lobe torsion. Are there any other radiographic changes that you guys are aware of that you might need to look for in patients with lung lobe torsion? So there's a couple of other things that you can look for. One is a bronchus going in the wrong direction. So I've only ever really seen that with big, deep-chested dogs that have right middle torsions. So what you tend to see is rather than a bronchus dividing ventrally, it tends to go the other way. So rather than having a bronchus that has a very thick lumen and then divides into smaller bronchi and bronchioles ventrally, it goes the other way. So you see a thick bronchus ventrally that then divides into smaller bronchi and bronchioles dorsally. Now, we're not really seeing that here, so that doesn't really help. But there is a change that is really quite pathognomonic for lung lobe torsion, which is you get this emphysematous type change affecting the pulmonary parenchyma. So if you guys think about what happens when a lung lobe twists, the bronchi becomes obstructed, and also the vasculature is obstructed as well. So the venous and the arterial flow to that lobe is disrupted, and because you get blockage of that lobar bronchus, the gas that is trapped within the bronchial lumen within that lobe, it tends to dissipate into the surrounding parenchyma and then sit in the interstitium. And what you get as a result of that is you get this this emphysematous type change to the lung lobe. And if you look very carefully at the cranioventral thorax here, you can see it has this really kind of speckly kind of gas pattern, and that's emphysematous type change affecting one of the cranial lung lobes. So the fact that this is a pug, the fact that we've got some pleural effusion here because of the effacement of the cardiac silhouette in both the lateral and the DV view. We've got some consolidation of the left and the right cranial lung lobes, and that's because of the disruption to the venous and arterial flow. So the blood can flow into the lung lobe, but it can't flow out, so that the lobes get really big and full and full of fluid, so they get consolidated. And then just to kind of nail it on, we've got this sort of stipply gas pattern in the cranioventral thorax in this right lateral view, which is indicative of this emphysematous type change, which means that lung lobe torsion is definitely on the differential list here, and it probably is top of the list here. So there is absolutely effacement of the ventral borders of the diaphragm here, but looking at the abdominal organs, they all kind of look like they're where they should be. So we can see the liver here, and we can see the stomach. So the gastric axis is about where it should be, so it should sort of be parallel to the last rib. So the orientation of the gastric axis now, I think, is normal. And we can't really see much of the caudal abdomen, but everything sort of looks like it's where it should be. We can't completely rule out that there's maybe some fat or something poking through this diaphragm here, but I think it's less likely. In this DV view, again, we can see the diaphragmatic crura, and they kind of look like they're intact. We've got the gas in the stomach here, and then a bunch of cranial abdominal organs that look like they are where they should be. So, I mean, it could be that this is just a really nasty pneumonia. So again, the changes here are predominantly ventral. It could be that there is a really horrible lobar pneumonia affecting the left and the right cranial lung lobes. And we've got some pleural effusion secondary to that really severe kind of lobar pleuropneumonia. But I think it's less likely. We've got this young dog. It's a pug. We know the pugs get lung lobe torsion. Acute onset dyspnea, that doesn't really fit with something like a pneumonia. We've got effacement of the cardiac silhouette in both views. So we're suspicious of a pleural effusion. We've got potential consolidation of both the right and the left lung lobes. And then we've got this emphysematous type pattern, although it is quite subtle in the cranioventral thorax. So lung lobe torsion is absolutely on the differential list. It's probably top of the differential list. And that's what this pug turned out to have. So this pug had, I think it was the right cranial lung lobe that was torsed in this pug. It did have a CT in order for us to confirm it. So I can't pretend that we were confident enough to send this dog to surgery just on the basis of these radiographs, but we were suspicious that there was a torsion here. And we did a CT, and the CT confirmed it. The doggy went on to have surgery and did very well. This is not a case from LVS, although we had a very similar one at LVS. If you don't have a CT scanner and you are suspicious of a lung lobe torsion, then you can pop the probe on the lobe that you think is affected, and you get a very characteristic change on ultrasound. So you tend to see gas permeating a very consolidated lung lobe. So the consolidated lung lobe will be hepatized, so it'll almost look like liver, and then you have tons and tons of little gaseous foci that look like little focal reverberation artifacts. It's a really characteristic appearance. So if you have a case like this and you don't have a CT scanner and you're wondering whether or not to refer it, then you could potentially pop the probe on the lung and look for those characteristic changes. And if you guys are interested, I can potentially send around a paper that contains some images of how that emphysematous type change looks on ultrasound in these dogs that have lung torsion. So there we go. So those are our 4 cases for this evening. So just to summarize them, we had the first case was a dog with Megaesophagus and an aspiration pneumonia. So you guys will know how to recognize that now. Number 2 was probably the trickiest of the bunch, I think, and that was a dog with a mechanical ileus, so an obstruction, secondary to a gaseous, almost foreign body, so plastic gas-filled foreign body, and a bunch of fabricy stuff, so a squeaker out of a teddy bear and the stuffing. We then had an absolute classic case of metaphyseal osteopathy, which Giorgio nailed, which was great, and then we had a pug with a lung lobe torsion. So there we go. Do any of you guys have any questions about any of the cases that we have covered this evening?
I just had a really quick question about the initial one, the Megaesophagus. Is the radiographic signs that we could see of that radiolucent sort of lines either side, is there any, are there any statistics how big it has to be, or are the signs of those enough? Because that's what I find a bit difficult sometimes.
So, I mean, normally you shouldn't really be able to see the esophagus. I mean, in big dogs, in a left lateral, then sometimes you can see it even if the esophagus is normal. And you sometimes see it if dogs regurge a bit when they're sedated or anesthetized. But if you can see the esophagus, if you can see the dorsal and the ventral wall, then that's almost always abnormal. Now, I mean, I had a dog. I had some radiographs that one of the vets at Cambridge asked me to look at. It was a cavy, and they were concerned that the dog was in failure. And this dog, I don't think it was in failure, but it had a dilated esophagus in pretty much every radiograph that they'd taken. And this dog, I think, was very aerophagic because it was really stressed and really wasn't coping very well with being restrained in lateral recumbency. Now, that dog technically had a Megaesophagus, but I think it was incidental, really. It was just because it was a little bit stressed and a little bit dyspneic, and it was gulping air down. So radiographically, we were able to say that this esophagus is abnormally large and filled with gas. It's diffusely dilated, so that's compatible with Megaesophagus, but it's probably an incidental finding here because it's probably just aerophagic. So if you can see the dorsal and the ventral wall of the esophagus like that, so if you've got this dorsal tracheal stripe sign, then I think that's abnormal. I mean, if this dog was anesthetized or sedated, then you could just be like, well, it could just be secondary to the sedation or the anesthetic. But in a dog that's conscious, then this is a real finding, and the fact that it's got aspiration pneumonia as well makes it clinically significant. So yeah, those would be the sort of things we'll be thinking about for that.
Thank you.
All right.
Sorry, just quickly, do you so do you see esophageal distension with what I thought it was, which was the sliding esophagus thing?
Yeah, so you were thinking about like a sliding hiatal hernia. So a sliding hiatal hernia typically will appear as usually best seen in the left lateral view, and you tend to see what almost looks like an ovoid soft tissue opacity just superimposed over the diaphragmatic crura. So you don't really see kind of a generalized esophageal dilation with a sliding hiatal hernia. What you'll see is a soft tissue opacity in the dorsocaudal thorax, superimposed or effacing the margins of the diaphragmatic crura. So this diffuse esophageal dilation that doesn't really fit with a sliding hiatal hernia. I mean, you can see Megaesophagus in dogs with a GDV, for example, but again, there's other changes there that are much more worrying if you have a GDV. But you don't tend to see it with sliding hiatal hernias.
Okay, thank you.
I mean, you can see it with like a gastroesophageal intussusception, but again, you see other changes. You usually see like a big soft tissue structure within the lumen of the esophagus at this sort of level.
Right.
Yeah, but not with a sliding hiatal hernia, no.
Sure.
And sliding hernias they're tricky to see at the best of times. And I mean, when we were trying to diagnose those at the RVC in like brachycephalic dogs like Frenchies, we try and do dynamic studies. So we'd use the fluoro to try and diagnose them, because you got to be super lucky to just happen to be taking the radiograph at the point where the stomach is herniating through the hiatus.
Right.
All right.
Yeah. Thank you.
All right. Any other questions about any of these cases?
Sorry, I just joined late. I just wanted to know what the eventual diagnosis was for the first case, for the Megaesophagus.
Yeah, so absolutely Megaesophagus. Megaesophagus, I can't tell you why this dog had a Megaesophagus.
Oh, okay, then that's fine. Yep,
Yeah,
that's fine.
and aspiration pneumonia. So it's got this focal increase in opacity in the left cranial lung lobe. And in the right lateral view, there's a couple of layer bronchograms just superimposed on the cardiac silhouette. They're kind of tricky to see, but they're definitely there. And the trick was to see the Megaesophagus and then see this focal increase in opacity in the DV view on the right cranial lung lobe, and then have a look at the right lateral and potentially then spot these little layer bronchograms to nail the diagnosis of aspiration pneumonia.
Okay, great. Thank you.
All right. No worries. All right. Any other questions? No? Okay, great. Well, thank you guys for joining me this evening. I'm pretty happy with the way that Teams has performed. So we haven't really had any problems at all. And as far as I can tell, you guys have been able to hear me. I've been able to hear you. And hopefully all of you have been able to see all of the slides and see my funky little laser pointer as well during the discussions. So Teams has gone well. So hopefully we will be able to do more of these. Plan is to potentially do them at least once a month, and the last Wednesday of the month has been touted as the best time to do it. So yeah, if you guys would like to join me next month, that would be great. I'll send the invites out. The more the merrier, essentially. And thank you very much for
thank
joining
you,
us.
Ian.
Thank you, Ian.
It's been great.
No worries.
Thank you.
Great. Thanks, guys.
Good.
Thank you very much, Ian.
Sorry,